la mesa anterior, que era sobre ablación de fibrilación auricular, ahora un problema muy nuevo, muy inquietante, que es el de los fantasmas de las microembolias y de quizá las complicaciones que no vemos y que por no verlas no entendemos o nos pueden crear problemas en el futuro. Y tenemos un grupo de ponentes muy interesante para cubrir esto. Jorge Pagola Pérez, del Hospital Universitario Vall d'Hebron, Claudia Herrera, de Ludwigsburg, que tiene para nosotros el valor de que nos va a traer una visión de otro país distinto, Alemania, otros enfoques. Y finalmente David Haynes, de Bowman Hospital en Michigan. David, yo tengo el privilegio de haberle conocido durante muchos años. Hicimos cositas cuando éramos pequeños los dos. Él presentaba cosas experimentales. Y aquí añadiré que in honor of David and his visit, he doesn't speak Spanish, and we have decided, I'm responsible for that, I'll bear all the responsibility. We have decided to make all presentations in English, even though some of them, the slides may be in Spanish. The idea is that he can participate in the discussion with all the information at the end. I'm sure the audience will be able to follow English, and there are lots of illustrations anyway on the presentations. For the discussion, we will start in Spanish, and whoever wants to ask a question in Spanish, it's fine. We can translate it or whatever if necessary. But I warn you that this will be a very international session, not German. Claudia, I'm sorry. It'll have to be English. Anyway, with no more to do, you want to introduce...
Muy bien. So the first...
Of course, everybody knows Tomás Latino from Hospital Gregorio Marañón. That's why I didn't introduce him.
So thank you. The first one who's going to talk today is Jorge, as he said before, and he's coming from Vall d'Hebron, so we are raring to hear you.
Okay, thank you. Thank you, Mr. Chairman. Well, first of all, I would like to thank the committee to invite me here today to discuss some points about the microembolisms. Well, this is the index of my talk, and as you see, I want to try to find or define the microembolism, what is a microsignal and what is a microembolism, trying to differentiate each other. We can use an online detection for the detection of microembolism. I try to explain you how there are several cardiac emboli sources, as you know, and we will try to figure out. And what is the main clinical relevance after the microembolization? Well, I'm a vascular neurologist. I work every day with this kind of machines, with this power Doppler machine, and this is, for me, the easiest way to define what is microembolism. As you see in the figure, this microsignal is the way I can define this microembolism, like a higher ultrasound reflected when we try to check or to assess the flow of the midocellular artery, as you see in this simple CT. This is transcranial Doppler monitoring. It's our protocol in our unit. In the video, you can see how these micro signals in this spectral waveform, because we just administered the contrast like LevoBeast. It's an example to see how it's the micro signals in the transcranial Doppler monitoring. Well, this is a simple B-spectral mode. You can see the flow of the MCA artery and ACA artery, and this is a unique and that's isolated microemboli, pretty easy to diagnose, but sometimes we have this kind of spectrum. And so as you see, this has several microsignals, only one microemboli. It's not that easy to diagnose. So we need a very good established criteria to define what is a microembolism. This is a transient signal more than 3 dBs. It's lasting more than 300 milliseconds, unidirectional, and we can hear a moan in the same time we are seeing the microembolism. Well, sometimes it's not easy to differentiate what is a solid microembolism or gaseous microembolism. But we could use an online automatic discriminator as the multi-frequency PW mode Doppler, because at a higher frequency, the solid microembolus reflected more ultrasound. As you see, this is a higher frequency, 2.5, and this is 3 dBs and, in the solid microemboli, and in the gaseous microemboli, you see a 4.5 in the dB. So clearly, this is a solid embolus, and this is a gaseous embolus. Well, even we could know where the emboli come from. This is a study when we can see the prevalence of the microembolus in the different cardiac source of emboli. As you see, this is an infectious endocarditis, a left ventricular aneurysm, a thrombus inside the heart, dilative myocardiopathy, non-valvular atrial fibrillation, and a prosthetic valve. You see, it's the incidence of microembolus in this kind of diseases is not so low. But not only in these diseases, but in invasive diagnostic procedure as coronary bypass, artery grafting, angiography, we can see even microembolus in these procedures. But, okay, we have our solid microemboli. We know the patient is a bit damaged or not. Are they really harmful or not? Well, if after the procedure we check the patient, we examine the patient, and we see a facial weakness, it's obvious we are under acute stroke. So in these cases, please call your acute neurologist to diagnose the patient, because it is an acute stroke. But if we have a solid microembolus, the examination is normal after the procedure, okay, we could perform an acute MRI. This is a DWI MRI, and this is another way to check if we have a stroke or a hyperintensity, that is a microinfarct. This is another imaging modality, like FLAIR, that we can use to be even more accurate. Well, and in this study, you can see how it is in how many microembolization we can find after a cardiac catheterization. You see, this is again, this is underwent acute MRI, and the percentage of the infarct they found was 22%, 50%. It's again, it's not so low. And in this review, the authors conclude that one of the main factors that could explain this acute stroke after the procedures was the length of the procedure. What it means is the same as the chance of finding a thrombus inside the catheter, or if the patient have a severe aortic plague and the cardiologist involved didn't know that. Well, not only stroke could be the problem here, we could have also a cognitive impairment after this microembolization. As you see, again, this is DWI lesions, ADC map. And in this study, the authors found that in the group that patients have WI lesions after the procedure, this mini-mental state examination score was lower. This is a good paper, but the main block wrote here, it's a mini-mental examination. Probably it's not the best test to assess these kind of problems. Okay. What about after cardiac surgery? This is a pretty good paper. This is a review paper. You can see several randomized studies, and then all of them is not so clear the relationship between hits and cognitive impairment. Hits in this way means the microsignal that we can find in the TCD Doppler monitoring. This is why the number of patients in this study is quite small. It is pretty hard to find any differences with this number of patients. And there's a lack of battery testing, neuropsychological testing in this review. I mean, if each study use a different battery test, it's pretty hard to find some differences in this case about cognitive impairment. So I would like to conclude with saying that transcranial Doppler is a feasible technique for monitoring microembolisms. The relationship between microembolisms and cerebral microinfarction is well established. We need more studies to assess the association between microembolic signals and cognitive decline after cardiac surgery. Thank you.
I think it's better just to leave the questions for the end of the session, just to go ahead with all of them.
Yeah, okay, after this nice introduction, thank you. And we are going to get closer to atrial fibrillation now, and Dr. Claudia Herrera will speak about the incidence of microembolism, brain microembolism, after cardioversion and ablation of atrial fibrillation. Claudia.
Thank you very much. And first, I would also like to thank the organization for inviting me here. It's a great pleasure for me to come back home and give a talk, and I hope to say something interesting too. So, as you all already know, atrial fibrillation is associated with quite a lot of morbidity beyond the symptoms that we are trying to treat with our ablations. This one is one of the most feared ones, the fact that patients with atrial fibrillation have much higher incidence of stroke, of major stroke, and that's why those patients also have to receive anticoagulation, most of them for the whole of their lives. These patients not only have a higher incidence of stroke, independent from other cardiovascular disease, but they also have a higher mortality. And what has already been seen, getting nearer to this microembolism, is that these patients, independently from ablations and other kinds of interventions that we can make, have a higher prevalence of silent microembolism in routine MRIs that were performed because of something else. That also gives us the idea that those patients during their life in atrial fibrillation have these small embolic events. What has also been described is that patients with atrial fibrillation here in a very big group of patients presented a higher incidence of dementia from all causes, which gives a strength to this relationship between microembolic events and cognitive impairment in those patients. This is a a slightly smaller study, but I wanted to present it too, because in this study, they even made a differentiation between paroxysmal atrial fibrillation and patients who had a chronic atrial fibrillation, persistent atrial fibrillation, and so that these patients with longer episodes of atrial fibrillation did even have a bigger cognitive distress compared to the ones that had paroxysmal atrial fibrillation, which could gives us the idea that the amount of time the AFib burden plays a role in the incidence of this microembolism and in the cognitive decline. Well, ablation of atrial fibrillation, that's why we are here. It's a technique, a very good technique that has been evolving a lot in the last 20 years with the goal of rhythm control in patients with atrial fibrillation. At the beginning, we were trying to have complete rhythm control to completely eradicate the atrial fibrillation. Now, we have also seen that there are other things that can be achieved beyond this complete elimination of atrial fibrillation, which is a decrease in the AFib burden, and maybe just with that we could also decrease the amount of microembolism and the incidence of this dementia and this cognitive decline. Of course, on the other side, the ablation itself has its risks, and we all know from the very beginning that there are strokes associated with the ablation itself, with an incidence that is around 1%. Quite constant among the data that are published. On the other side, we have also very nice data. For example, this data on a very big group of patients that were just prospectively followed after an atrial fibrillation ablation in many centers in the US, and where they saw that even patients with a high CHED score, where one would expect that the patients had a lot of stroke events not being on anticoagulation, some of these patients were left off anticoagulation. Of course, it was not a prospective study, it was just something observational, but those patients presented extremely low rates of embolic events after a catheter ablation of atrial fibrillation, so that our stratification that was valid before the catheter ablation might not be useful anymore after the ablation, because we have modified some things. So there is still something good. And the same group that talked about the higher incidence of dementia, of all-cause dementias in patients with atrial fibrillation, has also described that patients after an ablation of atrial fibrillation have incidences of dementia that get back to normal. So that even if we are getting success rates of 60–70% that are quite homogeneous, no matter what technique we're using, it seems that just by decreasing the AFib burden, we might be doing something good in the direction of decreasing the incidence of dementia in these patients, which would be very nice and very positive. The only dark cloud in this story was the appearance and the recognition of these silent microembolic events after ablations of atrial fibrillation. The whole thing started with this very small study from 2006. This German group made MRIs in 20 of their patients after an ablation of atrial fibrillation. In some of them, there was a previous study before the ablation, some that were the last ones. The first one were just the study after the ablation. And they found 2 patients that was a 10% incidence with fresh lesions, with new lesions in the MRI after the ablation. One of these patients, when they made an accurate examination, presented even a discrete hyperreflexia in the contralateral side from where the lesion was seen. So that suggested that it was really an ischemic event that would have been unrecognized if there had not been a neurologist that had gone there and just took a look at it. After this very small study, 2006, 4 years later, came the big study with 232 patients from the group from Gaeta, where they had 1 patient that had a symptomatic stroke, incidence from 0.4%, quite in accordance to other data that have been published, but an incidence of 14% of silent microembolism. So concern started about thinking what is exactly the meaning of this microembolism, where do they come from, how can we avoid them. In this second work from Gaeta, he tried in these 232 patients to look for factors that could predict the appearance of this microembolism, and found at the end that the anticoagulation and the cardioversion during the procedure could be predictors of the appearance of this microembolism. After these two works, in the last 3 years, quite a lot of papers on this topic have been published with different techniques, with different amount of patients, and I'm going to try to give a summary of them and to also clarify a little bit why are there such different incidences, because when you start reading it becomes quite quickly a little bit unclear what is playing a role on that. So I'm going to start by the studies that involved just patients ablated with conventional irrigated tip radiofrequency catheters. And here you see, if you take them all together, there are a little bit over 700 patients, with 4 patients that presented clinically neurological symptoms, including this one that had just this very slight abnormality in the neurological examination. The other 3 ones had a clear stroke. And that comes to an incidence of clinical stroke of 0.5%, so this is more or less what we would expect. And the incidence of this microembolism in the MRI after the procedure are varying. Actually, just for irrigated tip catheter, the variation is not so big. It varies from 6.8. This one is a figure that is quite different from the other ones, because all the other ones stay maximally at this 15%. There are, of course, other studies that have been made with other kinds of catheters. This is a table just summarizing the one-shot catheters. Of course, the one that had raised the most concern were the first figures that were published with the PVAC catheter that were quite high, with incidences of 40% of microembolism, and that had been improved just by modifying some technical aspects on the ablation using a PVAC catheter that Dr. Haynes is going to explain us, I think, in quite a big detail, so I'm not going to go a lot in that direction. As another one-shot catheter, we have the cryoballoon. Here the figures are quite good, I would say, excepting for this 50%. I will comment on that afterwards. But the other ones are all below 10%. And there is just one figure using the mesh catheter, just with 20 patients, is quite low, 26% quite high. Why are those differences? Even using the same catheter? Well, of course, as I already mentioned, a lot of things were done differently, not just the catheter that was chosen for performing the AF ablation. Just starting with conventional irrigated tip radiofrequency, well, it is not the same whether you do segmental PVI, just ablating for the entry sites around the vein, or whether you're targeting a really wide circumferential PVI, or whether they are trying to do lines, even to do cafes. There were really works where patients received a very wide ablation, and other ones where they received a very small ablation. There is maybe a very small trend that shows that the smaller ablations could have a little bit less of embolic events, but there is absolutely no clear trend. This group from Japan were the only one that found that cafe ablation could be related with the appearance of the microembolism. But there is really no clear trend where we could say if you ablate less, then you're going to have less microembolism. And of course, something that plays a very important role, and that my colleague already discussed a little bit, is how you define the lesions. Because most of these studies were done with MRIs, all of them were done with MRIs using diffusion-weighted sequences to detect these embolic events. Diffusion-weighted sequences detect cellular edema. It's an extremely sensitive technique for detecting embolic events, and the lesions are visible after minutes. It's extremely fast. more or less half of these studies combined also flare sequences. Flare sequences are a little bit less sensitive because they are a little bit more specific for cellular lesion. And lesions are seen a little bit later, but at last 6 hours after the intervention. So that should have been a problem for the studies where the MRI was done 24 hours after the PVI. Now let's take a look at the published incidences of these microembolic events according to this definition of the lesion. And here you see, for example, that this very big, this high incidence of 21.4% is in a study where they just took a look at the diffusion-weighted images and there were no flare sequences done. So that maybe here we are seeing some temporary edema that is not going to end into a real cellular lesions. And then we are seeing more of what we would see by also matching with flare sequences images. Although this is not completely consistent, these studies here also used only diffusion weighted and ended up with figures that were a little bit lower. We have in another table later another possible explanation. You really have to take a look at everything. The studies with one-shot catheters were done, most of them with a combination of diffusion-weighted and flare sequences. The only one with PVAC that was done just with diffusion-weighted was the one by the group from Denneke, and ended up also with quite a high figure. And this one that presented, I already commented before on this one, on this 50%, also used only diffusion-weighted, and it was the only study among everything that has been published to date that used a 3 Tesla machine. All the other ones were done with a 1.5 Tesla machine, so that might have played a role too. That's why these studies are so difficult to compare to each other. There is only one study that published both incidences, the one that they have just performing diffusion-weighted sequences, in this study from this German group with PVAC, and they had an incidence of 27% of silent embolic events with diffusion weighted. After taking only the patients that have an image also in the flare sequences, the incidence of the events dropped from 27 to 8.1%. It's just a single study, it's not a lot of patients, it's 37 patients, but it also confirms this idea that only performing diffusion weighted is maybe oversizing the effect. That is of course a cause of care, but what we really care about are real cellular lesions. If the cellular has a little bit of edema and recovers, then it shouldn't be so problematic. And what about the anticoagulation? That has also been a matter of concern. There have been not a lot of studies that have been performed under running anticoagulation. Most of them were done with a bridge into heparin and with different cutoffs of ACT. I have on purpose put the studies on a chronological order so that you see that the anticoagulation pattern over time has become more and more aggressive. And well, this is my personal opinion, but maybe we are overdoing in the other side. Because actually, by going from bridging from heparin and ACT scores over 250, the first published incidences were 10%, and the last one, with quite aggressive anticoagulation and ACTs over 300, are talking about an incidence of 12.2%, and both of them are defined by diffusion weighted. So anticoagulation is important, might play a role, but is not everything. In the case of one-shot balloons that are using also very, very big sheath, anticoagulation has also become a concern, especially in the case of the PVAC, and that's why I was saying that maybe we're overdoing it, because this last study performed with a PVAC that ended up with an extremely good incidence of these silent embolic events of only 1.7%, that was one patient actually in the whole cohort, was done under a very aggressive anticoagulation, because the goal of the ACT was over 350, but the mean ACT was almost 450, which is extremely anticoagulated. And of course, the authors came to this very low figure. And now it's very difficult to figure out, because apart from that, they also did many other things. And it's very difficult to take apart what is contributing to what. But I would say the rest of the data is not really suggesting that a very, very aggressive anticoagulation is able to drop the microembolic event ratio so importantly. Many of the studies has, of course, tried to look for predictive factors of these embolic lesions. And actually, they failed to find a common factor, maybe excepting for the PVAC when it was compared with the two other catheters and with the initial technique that was 2 years ago. These were these two studies comparing the three techniques, and both of them just found the PVAC as a predictive factor. But apart from that, there appears to be a certain influence on the patient itself. So there were two studies that found the age of patients as a significant contributing factor, and a lot of them found a trend to presence of spontaneous echo contrast in echocardiography, or the technique that you use. I also mentioned about that, ablation of CAFEs, coronary artery disease, the volume of the left ventricle, septal hypertrophy. The further study that had been done afterwards were not able to reproduce the first results by the group of GAITA, and no further study has been able to find the anticoagulation during the procedure or the cardioversion as a predictor for the appearance of this microembolic event, so that it seems to have been just a statistic coincidence of this group. I think also the problem is that this has been done with different catheters, with different strategies, which I had already said. And in the case of the PVAC, in these studies, the PVAC at that stage, with the technique done in that way, was really causing a lot more of embolic events, and then it statistically completely eliminated everything else that you could have seen. And just a couple of words, because my colleague already spoke about the transcranial Doppler, because I think it's very nice. We have seen this all varying incidences, and many authors have tried to do statistical analysis and trying to look for possible factors that are increasing the risk for having these microembolic events. But I think the important part of it is understanding where they are coming from. Because if we are able to understand what we are doing wrong, then we are going to be able to understand how to do it right. And there are two studies using transcranial Dopplers that give a couple of interesting insights. This is one with 200 patients where they performed transcranial Doppler, and I just wanted to talk about these figures here. These here were different phases of ablation where they were registering whether they were able to register embolic events with transcranial Doppler. Here, the phase 1 was just the puncture of the groin. Nothing was in the left atrium. And here, the phase 5 was after removing all sheath from the patient. And as expected, and we are very happy about it, there were absolutely no embolic events detected on those two phases. There were 5 minutes, 10 minutes of it. It was not a very long register. And everything was happening in these two phases. Phase 2 was after the transeptal puncture, flushing of the sheath, introduction of catheters, making the anatomy. No ablation was happening in phase 2, but there were already things happening on the embolic side. And of course, most of the embolic events were happening during phase 3, that was the ablation. Also to be said that this study was done with an 8mm non-irrigated catheter, and in that case, they also controlled for the formation of microbubbles in intracardiac echo, and they could find a very high correlation between these embolic events in transcranial Doppler and the appearance of microbubbles in intracardiac echo that were suggesting an overheating of the tissue. So that gives us a little bit more of insights. What is happening? Why are we finding that? This is another study introducing the cryoballoon and comparing irrigated with non-irrigated radiofrequency. I just wanted to point a couple of things of this table. The one thing They also measured here the occurrence of these embolic events during the placement of the catheter and during ablation, and also found that had happened too during the placement, especially with the cryoballoon, big sheath, placement of a very big device. This is really something that has to be taken with a lot of care. And as expected, a lot less of embolic events using irrigated RF compared to non-irrigated RF. Just one word to electrical cardioversion. I think that was done because of this suggestion that electrical cardioversion could be related with embolic events after an ablation or AF. There is one Spanish study of 62 patients that underwent an electrical cardioversion and an MRI 24 hours after the electrical cardioversion, where there were absolutely no silent embolic events. Absolutely none. Just to conclude, silent embolic events are a complication. I think it's not just an event, they are really a complication of our ablation procedures, no matter with what we are doing them. It's something that annoys us to hear it, but it's something important to know about. Their clinical significance is, of course, unclear because it's very difficult to measure that. Cognitive decline is something that is going to have in 10 years, but we are ablating young people that have a life expectancy that is over these 10 years, so we really have to care about it. Its incidence, which is also interesting to see, doesn't really seem to be correlated with clinical strokes, because even in all this PVAC series with incidences of 40%, there was not a single clinical stroke. It doesn't seem to be really correlated, doesn't seem to be a good surrogate of it. Its causes are multifactorial. The characteristics of the patient himself play a role, but the characteristics of the procedure, I think, are play the main role in it. And it depends then on the kind of catheter that you're using. Whether you're using radiofrequency, then it should be irrigating, trying to avoid sharing, be careful with big sheaths, be careful with flushing sheaths, and of course, on the PVAC, a couple of more of technological aspects. And just as a very last remark, just to say, of course, we know nowadays we are doing AFib ablation because of symptomatic indication, but actually we would all want to help these patients in what is really giving them problems concerning AF, which are not only symptoms, but this very high mobility, this high mortality, this higher incidence of strokes, and the higher incidence of cognitive decline. And we have to work to eliminate that incidence of microembolic events so that we are really able to say we are going to do AF ablation because we are helping the prognostic of the patients in general. Of course, waiting for that, I just had to say we are all waiting for the big studies that are going to help us take this decision and tell to our patients that we are also helping them on that side and not just with their symptoms and their palpitations. Thank you very much.
And now to finish the session, we have the pleasure to present Dr. David Haynes from Royal Oak in Michigan, if I'm not wrong. And, well, the title, you can see it here in Spanish, is Fisiopatología de la lesión radiofrecuencia y microembolias cerebrales, cómo se producen y cómo prevenirlas.
Thank you. I'd like to thank the meeting organizers and the chairs, and I appreciate that this session is being held in English, and you should appreciate my doing my talk in English because my talk in Spanish would be harmful to your ears, and I do not want to cause that. I'd like to follow up on what my previous speakers discussed. You know, when we look at patients with atrial fibrillation, we have simple goals to reduce symptoms, and I think we're effective in doing that. We would like to reduce stroke risk, and at least we have observational data that indicates that the stroke risk may be returned to the normal natural history of similar patients without atrial fibrillation. We'd like to reduce this alarming problem that we're becoming more aware of dementia and late cognitive impairment We see from trials, this is the meta-analysis recently published by Dr. Ruskin and colleagues showing the association of this finding with AFib. And we hope that by restoring patients to normal sinus rhythm, that we will reduce this risk as well. Ideally, we would like to improve survival, but that is clearly an unknown, and the prospective trials that Dr. Herrera mentioned hopefully will give us some insight into that. So we all make the decision, balancing risk versus benefit. We know that there are procedural related risks. We think that there are long-term benefits, but defining the exact balance in an individual patient remains a challenge. We heard about the transcranial Doppler data indicating that there are materials associated with catheter ablation that are being transmitted through the carotid arteries. And we've heard about the finding of diffusion-weighted MR and flare MR images post-ablation indicating that there may be cerebral injury. And we have heard about those studies. So the assumptions that we make here are that the cerebral lesions that we observed post-ablation are not artifact. They look like they are real. They're a result, we believe, of procedure-related microembolism, and asymptomatic cerebral diffusion-weighted image lesions could be markers for risk for clinical stroke or possibly late cognitive decline. So the question is, where are these microemboli coming from? What are the risks that put patients in harm's way? And the obvious potential sources are thrombus, air, and char or coagulum. Here's an example. This is an intracardiac echo image in the right atrium in a patient without anticoagulation. And one can see in the right atrial chamber all sorts of little floating debris that is created from thrombus formation and embolization on the catheter. It's quite striking, and these essentially go away or are markedly reduced once a patient receives intravenous heparin. And we have data that indicates that the rate of asymptomatic cerebral embolism is associated with how aggressive the ablation is, but also the tendency for spontaneous contrast echo. We also see that the more aggressive the anticoagulation, the less likelihood of ACE lesions. And this trial published last year shows that the cohorts based on the activated clotting time during the procedure, those patients with a lower ACT had the prevalence of ACE lesions in the post-procedure imaging. So it's clear that thrombus at least plays some role in the formation of these lesions, and appropriate attention and aggressive anticoagulation intra-procedure is critical. And people who have large atria and have evidence of spontaneous echo contrast probably benefit from more aggressive anticoagulation. And in our laboratory, we target ACT levels greater than 350 in those patients. Now, what about char and coagulum? Well, we've seen this ever since the early days of RF, and we know that the formation of boiling char and coagulum at the electrode tip is related to excess heating at that tip, and we know that the critical temperature at that tip is 100 degrees when the blood begins to boil. Now, that can occur at lower recorded temperatures because the peak temperature at the electrode tip is rarely reflected by the temperature that the system is reporting. That is, there is temperature variation around the tip, and it may measure 42 degrees at the very tip, but back at another contact point may be exceeding 100 degrees. And we know that electrode surface area relates to the degree of concentration of heating. So at a fixed power, as you get a smaller electrode surface area, you actually have increased power density. And heating, remember, is the square of power density. So you get much more concentrated heating with a tiny electrode. And you can see in this cartoon here, with a large electrode, you can deliver a large amount of power without having without having excessive power density and excessive heating. But if you have a small electrode, you have much more current density. You have much more power density and the much greater potential for excess heating. And when you look at a catheter like the mesh catheter that has very tiny electrodes, one would think that that risk would be much, much higher. So the PVAC, the mesh, are special considerations that cause us concern about excess heating, coagulum formation, and then potentially jar embolism. And you can see this is a recording taken from a multi-thermistor catheter, a conventional 4-millimeter tip catheter with 5 thermistors at the tip. And you can see that despite the relatively low temperatures recorded on one tip, we have one thermistor that is showing temperatures exceeding 100 degrees. And this thermistor is showing spiking temperature. What we know when we see these spikes is this is formation of coagulum, and then that coagulum breaks off and embolizes and more forms. And then finally, at this point in the ablation, there's enough coagulum that the entire surface area of the electrode begins to be covered, and then we get the rapid impedance rise. So this situation probably occurs frequently during clinical ablation, and since we are only recording from one thermocouple or thermistor, we are unaware of this event occurring. Well, to understand a little bit more about what was going on in terms of exactly what material was being embolized during ablation, we developed an animal model, a pig model, using an extracorporeal circulation loop. And you can see here that we have a femoral artery cannula here going through this loop and coming back to a femoral venous cannula. And in this loop, we had bubble detectors, ultrasonic bubble detectors, as well as an inline 80-micron filter to catch any particulate debris that might be generated. And we did transeptal catheterization and did pulmonary vein ablation with various tools. And this is a type of recording that we saw with the bubble detector. And these top graphs represent histograms of the bubble number and size that were collected or detected by the device. And then the bottom graphs represent the time series of bubble production during the course of ablation. And you can see when power comes on, we have production of significant microbubbles, and when power comes off, that's terminated. Now, what we found also is that when we would inspect the filters, we would see occasional flecks, and these are small pieces. This one was 250 by 500 microns of embolic char. We also saw white fibrinous deposits that may be clinically relevant, but probably were more of an artifact of our test system. But these char emboli were real, and this is an example of a kidney. You can see blanching at the kidney surface, and you can see on the section a piece of char that's lodged in the renal artery, resulting in a small infarcted segment in the kidney. So these systemic emboli did have potential clinical consequence. And what we noticed in particular with the PVAC was that when it was being delivered in the bipolar mode with the 10 electrode PVAC design, there was potential for overlap between electrodes 1 and 10. This essentially led to a short circuit and very high current density at that point that was not present when the catheter was widely deployed. And this was easy to do if it was constrained by a pulmonary vein, causing the radius of the circle to be smaller. And here's an example of the bubble formation in one of these cases experimentally. And when we turned off pair number 1, that's electrodes 1 and 2, so we eliminated the 110 overlap, the bubble production went away completely. And then when we delivered power in the same configuration to just electrodes 1 and 10, we saw this high bubble formation. So it would seem that the 110 overlap was a big source of the problem. And in fact, if you looked at the cases where there was 110 overlap compared to those without, that accounted for most of the particulate material that was generated in these cases. And this was borne out in a recent clinical presentation where a high prevalence of acute asymptomatic cerebral lesions were found in clinical setting where there was a 110 electrode overlap. So in response to this, the PVAC is redesigned. It's only going to have 9 electrodes that will completely eliminate the possibility of a bipolar short circuit between those two end electrodes. 1 and 9 will be essentially monopolar, and that will prevent that problem. Now, one of the things with a small electrode that it's dependent upon to get any meaningful depth of heating is convective cooling. With a very tiny electrode, temperature controlled, you get very narrow depth of volume heating and correspondingly non-transmural lesions. So these technologies depend upon passive convective cooling to allow for more power delivery, more volume heating, and deeper lesioning. And that's something that is inherent with both the PVAC and the mesh design. One of the approaches that the PVAC designers are using is going to a metal that has higher thermal conductivity, thereby helping to dissipate hot spots, helping the thermistor to more accurately record what's the true peak temperature at that electrode tissue contact point. And comparing gold versus platinum, you see that we're able to give higher powers, and as a result, lesions were trending toward deeper lesions. But more importantly, the temperature range recorded was much narrower, less variance in the temperatures. And so we think that this is probably not only more effective, but probably a little bit safer as well. The mesh catheter, when I looked at this design, I thought that this was a setup for hot spots and particulate embolic complications associated with its use, and I was concerned about that. We did a series of experiments with a similar type of extracorporeal loop setup and bubble detection, and in fact the mesh performed extremely well with very minimal excess heating. And here's one example of a type 2 microbubble burst, but that was an extremely rare event with this design. We did see a little bit of fibrinous material. Interestingly, we saw this as soon as we crossed the septum with our catheter, and saw some as well with irrigated RF ablation. This may be an artifact of the test system, or these things may be real. We're not quite sure. So the summary of the mesh data was that microbubble and embolic protection from the mesh was similar to irrigated RF ablation. We did see emboli with transseptal crossing alone. We saw histology that showed minute accumulations of platelet-rich material on the filter, but these events were infrequent to rare in terms of coagulated material collected on the filter. And I think part of the explanation is that even though these are very tiny electrodes, instead of being delivery from individual tiny electrodes, the electricity really acts more as a field effect. So these multiple tiny electrodes deliver current in a large area and virtually act as one big electrode and prevent any areas of very high power density and overheating. Now, finally, we know from transcranial Doppler, we know from this experimental model that we can generate material, embolic material, gaseous and particulate, but does that really account for what we see on the cerebral lesions? Part of the problem with animal testing is that most ruminates, pigs and goats and most dog species have a structure called the rete mirabile, which is this plexus of arteries that are in series with the carotid circulation. And embolic debris going up to the head doesn't make it to the brain. And we actually did a bunch of MRI scanning on the pigs, and all the brains showed no lesions. You saw that the kidneys had lesions. It's in part because the pig brains were tiny compared to the rest of the pig, but also because of the rete mirabile. So we wanted to determine, are these small particles really, can they produce the type of finding that we find in patients who are undergoing AF ablation? And so we used an animal model, beagles, which do not have the rete mirabile, and we did direct cannulation of the carotid with a 4 French injection catheter. And we did two things. We injected small particles, and these particles were denatured blood that were ground up and sifted through a screen to result in particles similar to the size of particles that we recovered on the filter in the other experiment. And then we also mixed up air with contrast and saline to create bubbles. And here's an example of a bubble injection through our system showing that, that we had a similar type appearance of these microembolic bubbles. Now, importantly, the volume of bubbles were about 2 or more magnitudes greater than the number of bubbles that we saw during actual ablation. But we wanted to have a proof of concept to say, does air microbubble cause lesions? And what we found was, in fact, we did get lesions. Here are gross findings in the brains of these animals. You can see in the particulate embolization, these leptomeningeal vessels showing accumulation of some of this debris. And associated with both air and particles, you can see small lesions, microlesions in the brain on gross examination that correlated with lesions on diffusion-weighted MR imaging. So real pathological lesions associated with these MR lesions. And the findings of these lesions, we could see that there was endothelial proliferation, there was glial cell activation, and there was perivascular lymphocytic infiltration. And these are findings consistent with ischemic injury. And we found these findings even in areas where the diffusion-weighted image dissipated by day 4. So the acute diffusion-weighted image, in the absence of a flare image, were associated with real ischemic injury to the brain, not infarction per se. There were scattered neuronal necrosis, but injury. And then the cases with positive flare images were associated with the larger lesions that we saw on diffusion-weighted imaging, and these were more extreme in terms of their histopathological findings. And then we had some cases where we had clear focal stroke with accumulation of particulate matter in larger penetrating arteries, and a clear finding of a focal stroke that had corresponding necrosis on pathology. Now, if you looked at all of these animals, and these are the data from those that underwent gaseous microembolization, you could see that the animals with no diffusion-weighted imaging abnormalities had no pathological lesions, whereas those that either died early or had DWI lesions all had histopathological evidence of cerebral injury. These are data from the particulate infusion, and we had similar findings. And we did have a couple of animals that had a number of particles injected into the brain, had no DWI lesions, had no pathological lesions. And that's either because they were large enough that they clogged up in larger arteries and the collateral flow managed to perfuse the brain. That's the likely mechanism. Whereas those animals that showed MR lesions all had pathological lesions. And these are data from a clinical study that I mentioned earlier, and showing the acute findings on diffusion-weighted imaging and the corresponding findings on flare in only a third of those patients, and in only one of those patients that notably had the largest lesion, a 14-millimeter lesion, positive on both DWI and flare. That was the only patient that had evidence of persisting abnormalities on follow-up scanning. So it may be a size and sensitivity issue as well. You know, with conventional MR imaging with a 1.5 Tesla machine, typical slice thickness is 3 millimeters, sometimes 4 millimeters. So you do not get that same spatial resolution that we're used to with CT scanning, for example. So you can miss smaller lesions, and it's not that they're not there, it's just that our sensitivity of our technique is limited. So in conclusion, AF ablation with both approved and investigational technologies can produce significant gaseous and particulate microemboli. Experimental embolization with gaseous and particulate microemboli can produce transient diffusion-weighted images and more persistent flare and T2 MRI lesions. The pathology of these lesions show varying degrees of ischemic injury, and asymptomatic cerebral DWI lesions may be markers for clinical stroke. So AF ablation may produce microinfarcts that could lead to cognitive decline, but the clinical question that all of us need to address is the opposing effects of lifelong AFib and cognitive decline must be considered. Thank you.
If the speakers will please come up. Thank you all for keeping to the time wonderfully. So we now have time for discussion. Queda abierta la mesa para preguntas, comentarios.
Thank you very much, Dr. Haynes. I have a question for you. You have shown, very brilliantly, that the reality catheter produced thrombi and the PVAC catheter produced thrombi as well. Now we have in the market, or is being introduced in the market, a kind of PVAC catheter with irrigation. Do you think that that irrigation is going to have a significant impact in the amount of possible coagulum that the catheter is going to produce, taking into account that the regurgitative catheter already produced coagulum?
Yeah, I think that the design of a circular catheter is not the issue as much as control is the issue. And I think it's possible, even with an irrigated catheter, to get excess heating and get coagulum formation. And we've seen in clinical studies, even with irrigated RF, a 5 to 10% incidence of the asymptomatic cerebral embolism. So I believe that control, you want to be as aggressive as you can without overshooting the mark. And how do you best achieve that? I think that some of the newer technologies, the pressure sensors that allow you to see what the catheter contact is, the near-field ultrasound imaging that allows you to actually see the growth of the lesion, things that will give us real-time feedback, perhaps in the future, real-time MR imaging to allow us to visualize the lesion formation. That's going to be the important, the best thing to allow us to use the maximum energy to create the clinically effective lesion without excessive heating. But I don't think that there is any one absolute fix for this problem right now. This is, we can minimize it, and I think that the changes that PVAC has gone through is going to put it in line with other technologies. But I think that this is something we just need to be aware of and do what we can in terms of good sheath management and aggressive anticoagulation to lessen that risk. I don't know if you guys have any other thought on that.
Dr. Merino?
Yeah, thank you. Very nice talk for all you three. I'm interested because microemboli or thrombus is part of the problem, but the other part of the problem is area embolism. So I wonder, because now the standard is to use regurgitative catheters. That means that we are continuously flushing our catheters, and I am sure that some kind of microbubbles may come from this continuous irrigation. Are you aware, or do you know if it will be possible to implement some kind of filters in our sheaths, in our catheters? Are they cheap? Are they available? Or what is your impression?
Well, you know, most of the perfusion systems have very sensitive bubble detectors, so theoretically you should not have the possibility of injecting air in through the lumen of a perfused tip catheter. But I'm sure that some air gets in to some patients. One of the things that interests me, though, and this is something that acknowledges that we may never completely eliminate this problem, but maybe we can do a better job protecting patients, are these devices that are being developed in particular for the TAVR procedure patients that deflect emboli away from the arch vessels. There is one device called the Umbrella, which you deploy. It opens up like a fan and actually sends debris past the arch vessels downstream. There's another device that is a cone-like filter that, again, sends embolic debris downstream. And it may be, certainly those are devices that probably should be used in most of the TAVR procedures where they're generating a large amount of embolic material, but it may be that that is something that we will need to consider as well for our AFib patients.
I just wanted to make one comment on that, because I also agree that the air is a very big issue, and I think the bigger the sheath become, the more that the most that can really be a problem, and particularly for the PVAC, for the cryoballoon that need very wide sheaths. And I know that for the cryoballoon, they had a very big deal getting a sheath that was really good enough not to catch air every time that the balloon was introduced. And something that hasn't been mentioned yet is that in these two last studies with the PVAC, which is the very low rates of embolism, they started introducing the PVAC underwater when they put it in the sheath, so that no air was catched by introducing the device. And I think this is in general important, particularly with long procedures where you have to change the catheters, with a cryoballoon procedure where you need two different sizes of the balloon, and you also want to check with a circular catheter in between if you don't have an achieve, and bearing that in mind, it's very important. Since I saw that data, and I saw the data from the transcranial Doppler, because we made 3 or 4 patients live, and we saw that just by introducing or removing the catheter fast instead of doing it slowly, you change the amount of embolism that you could register with the transcranial Doppler. So I started doing it a little bit slowly. It takes 1 more minute.
Dr. Almendral?
So I'm confused about what is the type of material that we are seeing there. Is that air embolism? Is it real thrombus material? Or is it debris? You mentioned, in different articles, people sometimes, they don't define. They say they are lesions, but can we tell by the MRI images what is exactly that is being embolized? Because for us as clinicians, I think that if it is a thrombus embolism, for me it's worse than air embolism. And would be something more difficult to imagine that it will clear away just by itself. So do we know exactly I think that in your preparation, in your experiment, you can tell very well. But in the humans, can we tell by the images?
I think that we don't know. I think that it's all of the above. I think that we certainly know that thromboembolism is an issue because there is data relating level of anticoagulation to occurrence of lesions. So that's at least part of the answer. Air, we know, has the potential for causing these. And in particular, one thing that I don't know the answer to, and I'm planning on looking into this, is that the bubbles that you produce with heating are different than bubbles that you introduce just from sheath introduction. Back in the early days of contrast echo, they would make albumin bubbles by heating because that would denature the albumin, and then they would stay present in the circulation for a long time. And so it's not only the size and number of bubbles, but the duration of how long they stay in the circulation that is important in terms of what kind of injury they cause. So I don't think we know, I know that we don't know the answer to that. I think that clearly the particulate debris is a big problem when it happens, and that's something that we've observed, and that's real. So, so I think you can approach the particulate issue and the bubble issue by controlling energy delivery as best you can, and the thrombus issue by anticoagulation. But I think we need to do everything, because I think they all have some contribution.
I would like to ask a question to Dr. Pagola now, because to me, looking at a little speck on the brain doesn't mean too much. I can read electrocardiograms, but I can't read that very well. Now, from the neurological point of view, are there any other known pictures, diseases, troubles, accidents, whatever, that neurologists may feel resemble this and may give us an outlook of what to expect?
Well, it's sometimes it's pretty hard to weight the lesion that we can find after procedure on the acute MRI, on the DWI imaging. For us, probably it's the location of the lesion, one of the major points. For instance, you can find a cognitive dementia if the lesion is in the thalamus, for instance. But if the lesion is the subcortical part of the brain, probably the patient remains asymptomatic. But I would like to remark that it's pretty important to examine the patient after the procedure, because sometimes it's the easiest and the cheapest way to find if we have some problems. And it's very, very simple. You don't need a pretty hard examination. It's only a facial weakness, a movement on one side or the other side. And because sometimes we forget this part of the
The problem is that most of the, I don't know, all of the labs, but in many cases we have the patient anesthetized, so you don't know if, he's confused and you don't know if it's an effect of the anesthesia or something's happening. You only check that the patient is moving all the limbs and that's it, but you cannot do more.
Anyway, if you have a little doubt, it's better to call us rather than wait and perform a CT. Or I would like to say something more. Sometimes about the solid microembolism, sometimes you have a higher frequency ultrasound reflection with the solid microembolus. It's higher than the gaseous microembolus, but in the real world, it's pretty hard to differentiate each other. But this is a technique, it's only online multi-frequency Doppler, and you can use it if you are really interested in it. Oh.
Okay, thank you. I wanted to ask just one question to Dr. Herrera. Well, you mentioned that there were two important moments regarding microembolic events, and one was the moment in which we performed the transeptal puncture, and the other one was when we were ablating. But, well, you didn't mention anything about the end of the procedure. I mean, do you check if there's anything related to the reversion of the effect of the heparin? Because in some labs, they do not give protamine or something to antagonize the heparin effect, but we do, and I'm concerned about it, because I don't know if this can be related to some events.
Well, the data that I presented were, of course, just data done during an ablation, and they didn't revert the anticoagulation. They just checked this 10 minutes before and after the procedure, I think just to have a control of what was happening when we were not doing anything actively, what happened spontaneously. So I don't really have the answer, and I also don't know whether these showers on the transcranial Doppler are really the ones that are going to do the lesions in the post-procedural MRI. I think it's something that you cannot really tell. You should stop after the transeptal, do an MRI, and then keep on the ablation to get this answer. But concerning the anticoagulation, the current trend is to keep the anticoagulation as stable as possible. And that's why also the current trend is doing the ablation during ongoing anticoagulation. I've even heard people that advocate against the new anticoagulation drugs on these patients that are planned for an ablation, because you cannot ablate under ongoing, it's not advised to ablate under ongoing dabigatran or apixaban. And in our lab, for example, we do not revert the heparin. We send the patients with the sheath to the ward, and then they get ACT controls, and then the sheath are removed when ACT just drops spontaneously. And of course, if you have behind that an already therapeutic INR, then the patient is really covered the whole time.
Yes, one more question.
Considering that the initial mechanism for thrombi is denaturation of proteins, or blood proteins, because of the overheating, and that you start a process of you start the coagulation cascade, but you also have a problem of aggregation of platelets. Do you think that, or any of you think that maybe just fight the platelet activation through anti-aggregation could have any impact on thrombi formation?
That's a really important point, and we just have some small data that seems to indicate using clopidogrel and aspirin pre-procedure may have some protective effect, but we don't do that clinically. I know David Keene does that routinely, but I think most people depend on heparin alone, but that's a very, very important point.
Any other questions?
So now I think we can close if there are no more questions. And thank you very much to all of you. Nice presentations, and I think we are on time. So that's it.